Mm. Okay, so we'll start today's session. It's a nephrotic syndrome in adults. Okay, so it's not a very common long case, but I mean, it's medicine, so they can give anything for the long case. So that's why I thought I'll discuss this because other cases, I mean, you get to see in wards, you all will go through. You all can go through them at any time, and also nephrotic syndrome is also a potential SEQ question. Okay, so we will try to cover both in today's session. So in the long case, once again, two situations where it's more. First one is it's a new diagnosis, which is sort of like unlikely, and the other situation where the diagnosis is old, when the patient comes to you either asymptomatic just for the exam, or the patient comes with some complication. So if it's an old diagnosis, you can always ask this nephrotic syndrome. People, they will have a proteinuria diary, okay, and they will be well educated also about their condition. So if you ask whether they maintain somewhere in your history, if you think the dialysis, there's somewhere in your history, if you need to exclude nephrotic syndrome, then you can ask the patients like, do you maintain a diary for your proteinuria or something like that? Or you can ask whether they have had any childhood kidney problems when they were treated with prednisolone. I mean, you can ask the drug from with the drug name itself, because they will be well educated and they will be aware of all the drugs they've been taking. They've been taking the drugs for such a long time. Okay, so that is how you get a hint that this case might be going into the nephrotic syndrome side. So as usual, the demographic data of the patient along, I usually take the comorbidities then and there itself, so I get an idea of it. Sometimes might give a clue to what the diagnosis is going to be. So people with nephrotic syndrome usually present with either generalized body swelling or periorbital swelling or some form of edema. Okay, so if they have bilateral lower limb swelling, so these are the differentials you have to exclude. So congestive cardiac failure, nephrotic syndrome, CLCD, and then these are the other malabsorption, mixed edema, and things like that. So the first three are very important. And this is just for comparison. If it's a unilateral lower limb swelling, these are the differentials you have to consider, because usually now when there is a system failure, when there is a cardiac or kidney or liver failure, the distribution of the edema in the lower limbs will be bilateral. And if the pathology is one-sided, then something, usually some vascular problem is usually the cause, okay, of that side. And also, so if someone comes with periorbital edema, you might get a patient with periorbital edema, okay, and then you are thinking of, okay, this might be a nephritic syndrome or nephrotic syndrome. So what are the other than kidney pathologies, what else? What are some other conditions you can get periorbital edema? I have included. So allergic reactions, retinoblastoma. So these things, it's very difficult to exclude from the history, but in an exam, an examiner can ask, okay, so what are the other differentials for periorbital edema in a patient? Okay, so you guys can name a few things and then you'll be good to go. Okay, so in your HPC, so I use this OPDA format. So onset, progression, here is the distribution of the edema. So facial and periorbital, usually the cause is renal. If the distribution of edema is predominantly abdominal, then liver is the cause. And if the distribution is pedal, usually a cardiac cause, okay? Usually the edema is marked in the morning if the cause is renal. And usually the edema is marked in the evening, the dependent edema, if the cause is cardiac, okay? So once again, this is repetition. So differential diagnosis of edema in a long case. So I won't go through it again. Okay, so now I suppose this we are the cause of edema. We are thinking of a renal cause. Okay, so then what are the renal conditions that can clinically present with edema? Okay, now for example, now in your history, the patient will tell, okay, I have proteinuria and I have urine problems. So what are then most likely we are thinking of a renal disorder, right? So what are the different renal disorders that can present with edema? So first is the nephritic syndrome. Okay, so how do you clinically, what are the clinical things, clinical symptoms of nephritic syndrome? So they will have reduced urine output, which is oligonuria. They'll have a change in their urine color, and they will have hypertension may present as headache, and they might also have these uremic symptoms due to some entity of renal failure. Okay, so nausea, vomiting, pruritus, and things like that. So that's how you target your history towards the diagnosis of nephritic syndrome. Okay, so you will have to ask these things, and then another differential, another cause, renal cause for edema is nephrotic syndrome. So here usually the urine output will be usually normal. Okay, but there is significant edema and significant frothy urine. Okay, so those are the cardinal things in the clinical history you can ask, which will suggest this patient might be having nephrotic syndrome. Okay, and when it comes to chronic renal failure, so one important thing is now usually in Sri Lanka, usually long-standing diabetes, hypertension, or that CKDU are causes for chronic renal failure. Okay, so there you will, in your history there will be a picture of either long-standing diabetes or long-standing hypertension or things like that. Okay, so that will suggest a patient is having chronic renal failure or CKD. Okay, and there is this another entity called rapidly progressive glomerulonephritis. Okay, so this is also something I learned during reading during the prophy. It's also there in Kumar and Clark. So this is also a clinical entity. Okay, so some patients can present with sort of like a nephritic syndrome picture, but they very rapidly deteriorate. Okay, so clinically, then you tell these kinds of patients as rapidly progressive glomerulonephritis patients. Okay, so those are the 4 ways in which edema can present in when the cause is a renal cause. Okay, so you will, you can't definitely say from the history that this is the particular syndrome the edema fits into, but in your history you can try to elicit and tell the examiner that okay, you are thinking of all these things as a cause for renal edema. Okay. Okay, so then after finding the cause of the edema, which is renal, and then again finding whether it's a nephritic syndrome, nephrotic syndrome, or whether it's CKD, or whether it's rapidly progressive glomerulonephritis, we need to find an etiology for the edema. And if it's nephrotic syndrome, we need to find an etiology for it. Okay, so there is this primary type, and the cause is idiopathic, and then there are secondary causes of nephrotic syndrome in adults, which are important to exclude. Okay, so one is this autoimmune disorders, and especially SLE can cause a nephrotic syndrome type of picture. Okay, and then there is diabetic nephropathy, and then there are certain drugs, and then there are certain infections like HIV, hepatitis B, hepatitis C infections. And when it comes to malignancy, the one malignancy we must know which causes nephrotic syndrome in adults is multiple myeloma. Okay, there's heavy proteinuria in that too. Okay, so once you try to exclude, so in your history what you should do is to ask symptoms of SLE. Okay, you can ask about the malar rash and the alopecia, and the photosensitive areas. Okay, and then if they have if the female, usually it's a female was trying to conceive recurrent miscarriages and things like that. And for diabetes, so it will be pretty obvious there will be a long-standing history of diabetes along with an entity of retinopathy. Okay, and for drugs, so that is theoretical. So you will have to know there are certain drugs which cause nephrotic syndrome. So name a few, and you are good to go. Infections as wise. So how you exclude? You can ask whether they have been going into any specialized clinics, or whether they have received blood transfusions. Okay, have they done repetitive investigations for certain blood viruses and things like that. Okay. And how to exclude malignancy. So your just general symptoms, loss of appetite, loss of weight, and if you are suspecting multiple myeloma or something, bone pain, back pain, and there's a whole list of things, symptoms of multiple myeloma. So you can ask a few and try to see whether this is myeloma is the picture. Okay, so after finding the etiology of the nephrotic syndrome, then we have to see whether this nephrotic syndrome is complicated. Okay, so as we all know, there is a hypercholesterolemia in nephrotic syndrome. So you can ask whether they have had any cardiovascular events, any cerebrovascular events, any evidence of peripheral vascular disease, and this renal artery thrombosis things, they present with abdominal pain and such. Okay, and then you can ask about infections, whether they have received antibiotics, during the episode of nephrotic syndrome, whether there was any coexisting infections and things as such, okay? And they can also present with pleural and pericardial effusions, okay? So you can ask whether they had any breathing difficulty, whether there was a tube inserted to chest, things like that will suggest in your history that the nephrotic syndrome in this patient was complicated, okay? And then there is this venous thromboembolism also, so they can present with DVT. So you can ask some symptoms of DVT, okay? And also nephrotic syndrome patients, they are hypovolemic, so they can go into acute renal failure, okay? So ask about decrease in urine output levels and such. So, so basically, if I give a summary, in your history, if a patient comes with edema, presents with edema, you have to find a cause. So usually with the three organs, you have to exclude the differential. So cardiac, liver, and your kidney. Okay, and if you think the cause is kidney, then you have to see, okay, which kidney syndrome or which kidney disease type of picture this is the cause for edema. Okay, so which we have discussed here. And after that, if the cause is nephrotic syndrome, and then we need to find some form of etiology for the nephrotic syndrome. Okay. So you have to exclude these connective tissue disorders, these diabetes, drugs, infections, and malignancy. Okay. And then after finding the cause for the nephrotic syndrome, then whether this patient has gone into complications of nephrotic syndrome. Okay. So if you highlight these things in your history, then it gives an examiner clear picture that, okay, you are well versed with you are well versed with the theory and you have applied that theory to the patient, okay? Okay, and if it's an already diagnosed patient, so as with any disease, it's very simple. So when the diagnosis was made and by whom, and it's also in the case of nephrotic syndrome, I mean, it's always your proteinuria levels and your initial serum creatinine levels, okay? And you can ask whether the etiology was found, whether a renal biopsy was done, okay, and what kind of treatment the patient was started on, the response, and any relapses, changes to due to the treatment, and any complications, okay, any complications the patient has due to the disease and to the drugs, okay. So under these few headings, you can easily finish off your HPC if the patient is already diagnosed, patient with nephrotic syndrome, okay. Then moving on to the systemic inquiry, which is your ask each system, the cardinal symptoms of each system. And then going on to your past medical history, if the patient has features of atopy, then there is an increased incidence of minimal change type of nephrotic syndrome, okay, the idiopathic thing. Past surgical history, drug history, family history, and then the social history as normal, okay. So that's basically for the history component in nephrotic syndrome. And then when it comes to examination, I mean, there's a whole list of things, but the most important things are the anthropometry, because you give, not very important in adults, but ideally, prednisolone and all should be given according to body surface area, the general condition of the patient, the pattern of edema to find which organ is affected, and a possible etiology. Okay, so in terms of nephrotic syndrome, so connective tissue disorders, lymphomas for malignancies, infective endocarditis, and things like that are important. Okay, so this is again also this I got it from the pediatrics book. So this is a very brief count of the important points in the examination in nephrotic syndrome. I mean, it's still applicable for adults. Okay, so after your general examination, a thorough cardiovascular examination is a must, because you need to find the patient's volume status. So JVP, pulse rate, blood pressure, and cardiac auscultation. Okay, and along with this capillary refill time and things like that. In the respiratory system, you should auscultate and check for pleural effusions, and abdomen for any tenderness. This peritonitis can happen. And so since this is a case of edema, whether this is there's an entry of CLC, okay, and CNS for higher functions, because people can go into uremic incontinence. When you say the it comes for diagnosis, when it comes to a case of nephrotic syndrome, so you have to mention these words like remission, relapse, whether this is a steroid sensitive nephrotic syndrome, and steroid dependent nephrotic syndrome. Okay, so it is all theory, so you guys have to go, I mean, there is no easy way around it. You will have to remember all these definitions. Okay, so I won't be going into detail, you can just read up on it. Okay, so that's how you tell the diagnosis. So then when it comes to investigation, so basically after your history and examination, so examiners you will usually ask, okay, they will, if you have given a good history and excluded all differentials and they have understood that you have excluded all your differentials, they won't ask for a differential diagnosis. They will straight away ask, what's your diagnosis? Okay, then you can give a complete answer like this. After that, they will ask, okay, how do you investigate this patient? So as with all the investigations, first you investigate to diagnose, and at the same time, if possible, assess the severity, find the etiology of the condition, and to identify complications. Okay. So this is the investigation panel to diagnose nephrotic syndrome. So you do a UFR, and in that you will get protein plus, and sometimes in minimal change disease, there will be a few RBs. And urine microscopy, you get RBC casts and dysmorphic red blood cells if the picture is nephritic. Okay. And also to quantify the proteinuria. So usually a nephrotic syndrome patient will have, so different book says different things. More than 3 grams of per day of proteinuria is considered nephrotic syndrome, but some people say 3.5. Okay, so 3 to 3.5. And then you do your serum protein levels and your lipid profile, because there's increased LDL and triglycerides. Okay. So this will help you to diagnose the nephrotic syndrome and assess the severity of the proteinuria. Okay. Then these are the investigations, some of the investigations you do to find the cause for the nephrotic syndrome. Okay, so ANA is for this SLE, hepatitis B, hepatitis C is for hepatitis viruses, and complement levels also if there is an autoimmune disorder. Serum electrophoresis for multiple myeloma, and ASOT theta for infective endocarditis and other things. And finally, there is no, I mean, you can't find any etiology, then you do a renal biopsy and see, okay, what type of inflammation and what, and you do these immunofluorescent markers and things like that. Okay. In addition to all these investigations, you also do a serum creatinine and serum electrolytes, because those are baseline renal function tests. Okay. Okay. Then when it comes to management of nephrotic syndrome, so there are general things and specific things. Okay, so what you can say is, if there is no emergency, if the patient is stable, you can straight away say, okay, I will manage this patient in not in the acute, subacute ward or something, normal general ward. Okay, so we talk about the patient's diet. So low salt diet, normal protein, low fats, and to control the volume state, so if the patient has edema, like pleural effusions and all, you might need to start using diuretics on the patient. So loop diuretics are used, and then and you can combine potassium sparing diuretics such as thiazides as well. So in patients with sometimes very low protein levels, so you have to give albumin. So you use salt-free albumin infusions for that. And to control the cholesterol levels, you use statins in adults. And usually ACE and ARBs, they are, even though they have an antiproteinuric effect, they are not used in minimal change disease and not used in the acute stage. Okay. And also we have to think about anticoagulation, because they are susceptible to DVT. Okay. But it's only indicated if there's severe hypoalbuminemia. Okay, and prophylactic antibiotics, if there is a history of infection along with the nephrotic syndrome episode, then you have to consider prophylactic antibiotics. Okay, and when it comes to specific treatment, so immune suppression targeting for the glomerulonephritis, and so if it's minimal change disease, focal segmental glomerulonephritis, so IgA nephropathy, and prednisolone is the treatment of choice. Okay. And then there is steroid sparing agents like cyclosporin, MMF, tacrolimus, and all. So those are like high stuff. So just remember prednisolone. So during the treatment, you have to monitor the weight, urine dipsticks for protein, the blood pressure, and your input and output of the patient. Okay, and same as pediatrics, these are the drug doses you use for nephrotic syndrome. So you guys, I mean, there's no easy way around it. You all will have to remember all this. I mean, at least the corticosteroid therapy. Okay, and no need to remember these other agents. So that pretty much covers nephrotic syndrome. We'll discuss an SCQ also. Then we can finish it off. Yeah. So this is from intake 33. Okay, 33 proper. They got an SCQ, and so let's take a look at it. So a 30-year-old previously healthy female presented with history of lower limb swelling, difficulty in breathing, and passing of frothy urine for 3 months. On examination, she was afebrile, had periorbital and pitting ankle edema. Her respiratory rate was 24, and blood pressure was 120 by 80. Chest examination revealed absent breath sound and a stony dull percussion note over both lung fields. There was free fluid in the abdomen with no organomegaly. So UFR, protein 3 plus, red cells nil, pus cells 1 to 2 for high power field. Okay. So what is the most probable diagnosis? Okay. So I mean, in the clear, I mean, usually once again in a medicine SEQ, they usually give some clinical picture and then they ask the post possible diagnosis because they are only expecting one diagnosis. Okay. So our job is to identify identify what these symptoms mean, what is the diagnosis, and try to give a complete picture as possible. Okay, so whenever this passing frothy urine business comes, I mean, definitely the cause is some kidney problem. Okay, patient's blood pressure is normal, so unlikely to be a nephritic syndrome. Okay, and has bilateral pleural effusions because there's a stony dull percussion note. So once again, it's pointing towards a diagnosis of nephrotic syndrome. Okay, and there was free fluid in the abdomen with no organomegaly. Means here they are rolling out CLCD because portal hypertension will cause splenomegaly. Okay, chronic renal failure won't fit into this picture because okay, fairly young individual, 30 years old, no known comorbidities. Chronic renal failure is unlikely. So most probable diagnosis here is nephrotic syndrome, but that's not the end. So you have to mention that this patient has bilateral pleural effusions and there's a military of ascites. So complete diagnosis will be nephrotic syndrome complicated with bilateral pleural effusions and ascites. Okay. So then they mention 3 possible causes for the above diagnosis. Okay, so now we discussed earlier. So there are several causes, right? Connective tissue disorders, diabetes, malignancy, infection, and drugs. Okay, so out of that, you have to be here a bit careful. So 30-year-old, I mean, diabetes cannot be a cause, right? Because 30 years old, unless it's type 1 DM and very poorly controlled, won't go into nephropathy. But connective tissue disorder, see there, 30-year-old previously healthy female, that is a possible cause. So SLE is something you have to include here. Okay, and then you can include, can always be some infection. So HIV, hepatitis viruses, all those things can happen. Malignancy, once again, at this age, 30-year-old, very unlikely. So malignancy is also a bit out of the picture. And then there are other causes like drugs, so gold, penicillamine, and things like that. So you can mention drugs, you can mention connective tissue disorders, and infections. Okay, so diabetes and malignancy are a bit unlikely at this age. That's why everything given in an SCQ is important. Okay, because they usually want very specific answers, and the whole point is to see whether the candidate is smart enough or he or she is well equipped with clinical knowledge to apply whatever the data is given and come up with the most possible causes. Okay. Okay. So name 5 investigations you would perform on her, stating reasons for selecting each investigation. So this is also where this is a fairly straightforward question. So once you identify this is nephrotic syndrome, then you just mention some of the nephrotic syndrome in routine nephrotic syndrome investigations and some after, and if you have more investigations to write on, Then you write some investigations to find the probable etiology. Okay, so they have already done a UFR. So what are the other investigations you can do? You can do a 24-hour urinary protein collection to quantify the protein. Okay, you can do serum albumin levels. You can do a lipid profile. Okay, you can do baseline serum creatinine and serum electrolytes. Okay, so those are some routine nephrotic syndrome investigations. And then you can do some investigations to find out the etiology. So you can do this thing, ANA, complement levels, and to for infections, you can do HIV screen, hepatitis B and C virology, things like that. You can write a few and then you cover up your 5 investigations. Okay. So extensive investigations did not reveal any secondary cause for her presentation. So this is most likely cause is idiopathic. Okay. Outline the management of this patient. So as discussed before, you can write case in, they don't say patient's breathing rate seems to be okay 24. So there's no acute medical emergency, you can write. So I would manage this patient in the subacute order, something like that. And then under general management, you write about the diet, you write about fluid management, you write about how to control, how to manage the protein levels in the blood, how to you give statins, and then you can write about the corticosteroid therapy. You can write about anticoagulation. So under those points, if you write, and you can write about monitoring. So fluid status, protein, albumin infusion, thromboprophylaxis, infections, controlling the lipid abnormalities, and antiproteinuric agents after the acute stage, and specific for steroid therapy and steroid sparing. So if you write around these headings, you probably will get most of the marks. Okay, and so you can, you guys will have to add. So you will get more marks if you can add the drug doses and things like that. You will get more marks. So that is nephrotic syndrome in medicine. So any questions? And also, if you guys have like more long case topics to do, like you guys can either DM me or send it on the group. Okay. Any more topics you are going to discuss? And I think the consultants are doing SCQ, so that's the best way to learn. So you guys are hopefully you guys are listening to those recordings as well. Okay. If no questions, we will end the session. Okay. It's a fairly short session. Reading up, where to read these things. So Kumar and Clark is the best. Okay. So I know it takes some time to read that book. But if you guys, there's no time to read Kumar and Clark now. So just read the summarized materials people give, and Fazil's lecture notes are also good. Okay. I know it's a lot to medicine. There's a lot to remember, but it's important to know that there's a lot to remember, and so it's important to know which points are really important and which you can forget. Okay. And always remember, it's good to know a bit of everything in medicine, because especially for a long case, they can give these very odd patients and not your classical cases. So it's good to know a bit of everything, and at least the basics of how to manage patients. Okay, there's just the very basics. No need to go into this sci-fi stuff. Okay, if that's it, I will end the session, and we will be doing PUO. Okay, in the context of endocarditis, infective endocarditis. Okay.